Right. It looks like we are live on Facebook. Great. So I'm going to go ahead and get started, and people can join in as we go along. I wanted to first start off with introductions so that everyone in the audience knows who all we have here on the screen today. I'll go ahead and get started. I'm Nastasia Ferreira, and thank you all for joining. This webinar is to discuss some of the findings from our Transforming the Carolinas research study that's been conducted over the last year, and I helped to coordinate this project. And so, Fred, do you want to join it? Go ahead next.
Yes, my name is Fred. I'm from Columbia, South Carolina. I use the pronouns he and him, and I run a nonprofit for the homeless called F&C Helping Hands nonprofit group. Also, I am a pastor, and I'll pass it on to Ames.
Hey y'all, good evening. I'm really thrilled to be here. My name is Ames Simmons, and my pronouns are he and him. I am a queer white transgender guy, and I'm policy director at Equality North Carolina, which is a statewide LGBTQ social justice organization. And I helped work on the policy portion of this study along with colleagues at Duke Law School. And I will pass it to Reverend Deborah Hopkins.
Good afternoon, evening to everyone. I am Reverend Deborah Hopkins, the pastor of Essentials for Life Ministries here in Charlotte, North Carolina. I'm also the founder and executive director of a nonprofit organization called There's Still Hope, which provides transitional housing to transgender adults who are homeless. And my preferred pronouns are she and her. And I'm going to pass it on to my dear sister. Tanya, go right ahead and take it away.
Thank you very much. Hi, I'm Tonya Petit. My pronouns are she, her. I'm in the Department of Social Medicine at UNC and work with Nastasia and Ames and probably a bunch of other people I don't even know on this call on Transforming the Carolinas. And I will pass it to, last but not least, Greg is ready.
I'm ready. How you doing? My name is Greg Green. I am a board member at the Harry Hancock Center, and also have a nonprofit organization, Transgender Awareness Alliance, that assists with name changes, gender marker changes, and all of the above. I'm also an author with just publishing my first book. So just want to throw that out there as well.
All right, thank you, everybody. So the way that we have this set up, I'm going to do about a quick 10-minute presentation to share some of the findings from our study. And then the remainder of the time we're going to use for a panel discussion with everyone here on the panel. And then we'll save some time at the end for a Q&A. I'm going to share my screen. Just a second. All right, can everyone see my screen here?
Mm-hmm.
So as I mentioned, the title of the study is called Transforming the Carolinas. And we sought to understand what are some of the things that get in the way of HIV care and prevention for transgender people of color living in North Carolina and South Carolina. Although the study was funded by CFAR, the Center for AIDS Research, and focused primarily on HIV and what it might take to end the HIV epidemic. But it had three aims that were really intentional around understanding what were the priorities for transgender people of color when seeking healthcare. So these three aims were to identify a regionally relevant structural, social, and individual drivers of disparities in HIV prevention and care engagement among transgender folks living in North Carolina and South Carolina. We wanted to map the community assets that are available to address the barriers and increase facilitators of HIV prevention and care among trans people of color. And we wanted to engage with community stakeholders to help prioritize feasible and acceptable HIV prevention and care strategies that we could actually implement. The study involved four key pieces. We did a policy analysis in partnership with Ames over at Equality North Carolina. We conducted a few key informant interviews with folks who work with or provide services to trans people of color. And we've done an online survey that is still ongoing, and a series of focus groups over the summer in both North Carolina and South Carolina. For the majority of this presentation, I'm going to focus primarily on the results from the online survey and the focus groups. And here are some of the demographics from our survey. So we've had, as I mentioned, 94 people complete the survey with an average age of 33, but a pretty large range of from 18 to 81. More than 40% were trans men, and a little more than 30% were trans women. And the remainder were gender non-binary or another gender identity. And I have those listed here. So of those five, a little more than 5% that identified as another identity, they identified as non-binary trans masculine, non-binary trans man, agender, or demi-boy. And we had 12.75% of people who were diagnosed as intersex. Our participants came from all over North Carolina and South Carolina. We had about 30% who were from the Triangle, so Raleigh, Durham, Chapel Hill area, about 22% that were from Mecklenburg County, 10.83% who were from Greensboro, about 10% from Columbia, and the rest came from all over Greenville, South Carolina, Charleston, South Carolina, Winston-Salem, and a few other places that did not really fit neatly into any of these categories. In terms of the racial breakdown, we had about 40% of the study survey population were white or Caucasian. A little more than 35% were Black. And then we had the next group would be Latinos, who were 11.29%. 4% were American Indian, and 2.42% were Asian. So one of the questions that we asked in the survey that was really important to this study was, what are some of the priorities for members of your community? And when we look at the results overall, the main priorities out of this list of 20 that came up were preventing violence, harassment, and bullying, access to safe, affordable housing, insurance coverage for gender transition related care, access to gender transition related care, and making it easier to change gender on identity documents. I went ahead and broke this down by race to see if there were any differences between what those who were BIPOC versus those who were white had to say about their priorities. And it's really interesting to see that the priorities were largely the same across both groups, with a few differences in where things fell. But what was the same across both groups was that preventing violence, harassment, and bullying, and also preventing police violence were among the top priorities for folks, regardless of race. And then also access to gender transition related care, affordable housing, and employment were all things that were important to folks. And this list included a list of 20 items that covered a large range of things. And then by gender, I broke it out between trans women and trans men to see if there were any differences in what people had to say about their priorities. And what was interesting is that preventing violence, harassment, and bullying still remained among the top priority for trans women, but moved down to second place for trans men. And then, as you can see, the main differences between the two is that insurance coverage is a lot higher for trans women. And then things like access to employment and affordable housing are relatively the same among both groups. And then among those who are gender non-binary or gender non-conforming, they also remain pretty much the same, looking at the same top 5 things among all 3 groups. Next, in the focus groups, we had 4 total focus groups, 3 of which were with participants in North Carolina, and 1 was with participants in South Carolina. And the main topics of these, the focus groups were, we talked about community norms around HIV, how do people feel around HIV testing, how do people feel around condom usage, things like that. And we talked about people's personal healthcare experiences when they go for care, whether that's for HIV care or care otherwise. And then we also had 2 activities. One activity in which we asked folks to rank their several intervention strategies, things like health behavior or education about health behaviors, and things like helping people make empowered decisions with their healthcare providers. And then we also asked folks to identify resources in their communities to address various barriers. And from that, we got a lot of generally really positive reactions. People had a lot of positive things to say about their experiences with their providers, and they talked a lot about a shift that they've noticed over the last several years. One thing that's really interesting about the focus group is that most of the participants were older in age. So a lot of the participants were at least 35 or older, and they all talked about having noticed a shift in how they receive care from when they first started seeing a provider to now. They did not say much about what they attributed that change to, but it seems important to highlight. And then participants talked a lot about having had to take agency over the types of interactions that they wanted to have with their providers. So things like teaching their provider that to start with their pronouns, like going in and saying, "Hi, my name is this, and these are my pronouns." They spoke a lot about having to make those sort of decisions very thoughtfully and intentionally in order to get the care that they wanted to have. And then one of the things that we asked participants was, what sort of things make the experiences with your healthcare provider go well? And here I've included some direct quotes from our participants. And this person was talking about when the provider actually listens, when they respect their name, and they take time to pronounce their name correctly, and they take time to acknowledge the things that they're saying to them. Next, I wanted to talk a little bit about the intervention strategy ranking activity. This activity, we presented a list of 5 questions or 5 strategies, and we asked folks to rank them in order of their importance or what they think is most important. And these are the top 3. So I'll just read them off. The first strategy that came in top, and this is across all of the focus groups, was to help individuals apply for and access various health and social resources. This includes things like health insurance, job readiness support, housing, nutrition, and legal services. Next, participants talked a bit about providing basic health education using culturally appropriate terms and concepts. And third, they talked a bit about helping individuals feel more confident and empowered in their interactions with their healthcare and social service providers. And so I wanted to share a bit about what people had to say about these different strategies and how they viewed them. So for the first one, linkage to health and social service resources, this participant had to say that they felt like the services are quite disjointed, and they'd like to not have to go hunting for the things that they need. They want to not feel like their services are in some hole in the wall secret place that they have to get to either on the internet or in real life to get access to the care that they need. In the same vein, another participant talked about if a provider is going to refer the patient someplace, that they should make sure that the place that they're referring them to is up on their training and that they know how to treat folks, in particular, how to treat trans. And then we talked a bit about health education and what that looks like. And this participant felt like health education was at the top of their priority list. And they mentioned that with their organization, they do provide some basic health and understanding of all of those things. And they find that to be foundational in order to help people get the things that they need. And they said that the things that they help people do is to understanding the terms, the concepts, how to go through the different services, how to navigate these things. And then they move forward with providing them with various tools necessary to help them move along. And for empowering interactions with providers, this person spoke about feeling as though when they feel that they can actually talk to their healthcare provider about what's going on with them, that's a really important factor in receiving care. They express often feeling afraid or feeling like people are afraid to tell the truth about what's happening to them. And they also talked about some racial differences with Black people in general not trusting doctors, and then feeling like Black women not trusting doctors, and then compounding that with Black trans people really not trusting doctors. So thinking about trust and how trust comes up in interactions with providers and how that may influence the relationship between patients and their providers. And along the same line of empowering interactions, this participant felt like if a person is empowered enough to talk to their healthcare provider or their social service providers about the things that are going on with them, everything else sort of falls into place. So they said, like, if you feel empowered enough to talk to them about stuff, then you're able to apply for more stuff. And what they were referencing in that section was they were saying that they feel like if they're able to tell their provider what is going on with their life, that they'll then be, by that interaction, be linked to the things that they need and be able to apply for the services and the resources that they feel that they need. And so for this last activity that we did within the focus groups, we did the asset mapping activity where we asked people on the focus groups to identify local or online resources to address some of the barriers that came up, some of the barriers that were present from the surveys and things like that. And so some of the resources, we have a whole resource document that we've created, which I'll share in the chat bar after I'm done presenting. But essentially, we asked them to find to tell us about what resources exist in their community and or online to address these 5 barriers, which were access to gender transition related care, access to employment, preventing violence, harassment, and bullying, making it easier to change name and gender and identity documents, and access to safe and affordable housing. And if you'll recall, these were all of the top priorities that folks identified in the survey. We got these pretty early on, and they have remained pretty much consistent over the course of the survey. And so now I wanted to talk a little bit about what's next. So one of the biggest pieces of this study was figuring out, well, what can we do? What sorts of actionable steps can we take to address the concerns that people have raised? And so we have recently received funding for a community health worker research study in which we'll be hiring and recruiting 10 people, hopefully trans people, to be trained as community health workers with our partners at the University of South Carolina. It's a 12 to 14 week training, and by the end of the training, they will have the skills that they need to become a community health worker, and will help them get certified as a community health worker. And so we are currently recruiting for this, and we're hoping to start that at the beginning of next year. And so if there's anyone that is interested in this part of the research study, or if they know anyone who might be a good person or a good fit for this study, I would love to have them reach out to me. And I will put my contact information in the chat bar as well, and these slides will be made available at the end of the study or at the end of the webinar. So now I'm going to turn it over to Ames, who has so graciously agreed to facilitate our discussion today. And I'm going to stop sharing my screen.
All right, we have fortunately had a panelist to join us since we did our round of introduction. So I wanted to give Naji a chance to talk a little about who you are and why you're here.
Well, good evening, everybody. My name is Naji Carter. I was born female. Now I'm transitioning to male. Basically, I want to share insight about how things have happened in the community and that things need to change because things haven't not gotten there yet. It's working on it, but it has to improve so much. I think it's going to be a definite good insight to people to let them know where they can get certain things from, and to let people know that we have a lot to do as far as making it known out there in the community.
So what this question is for everybody, just to kick off the discussion. What do you think that healthcare providers can be doing to try to address some of the non-clinical, non-medical aspects that people identified in the survey as being important? Like, what role do any of you see for healthcare providers in preventing violence bullying and harassment, for example?
As far as I'm concerned, they need to stop being vague. What I mean is that just because you see a person does not mean that's what they are. I've had certain instances where doctors have said he, and in fact it was a she, or have said she, and in fact it's a he. My whole thing is don't assume. Ask first, because like prime example, when I was in the hospital in the VA, I had started my transition, and instead of them saying, well, what do you want to be called, they automatically assumed that I was female. The fact was, I've already transitioned over to male. So don't assume. Just because you see a person for what they are, don't assume. Always ask first. That's been the basic problem that I've had amongst the community, amongst the providers, because they don't like to ask. They always assume. Same thing with phone calls. Always, ma'am. Oh no, I'm a female. I'm a male. Oh, I'm sorry. Don't assume. Always ask first. That's been my problem.
And in fact, when uh, healthcare providers reveal your status as a transgender person, that is a risk factor for harassment at a minimum and for violence. So other folks have thoughts?
Yes, I had a situation. I was telling Natasha earlier. I have a family member, distant relative that works at one of the doctor's office I go to, and everything has the doctor. They would always say, "Oh, Miss Fred, come in." And I'm like, "How do you get Fred out of female name?" You know. And my transition happened real quick. My beard grew in real quick. But I've learned to tell all the doctors just to say, Fred, don't call me by my last name. I think that's who I am. And one of the doctor's offices that I have a better thing with is Dr. Ada Stewart, who's at the Waverly Family Clinic. I don't know if she's watching right now or not. She lets them know, go by their name or whatever pronoun that they want to be said, be called. It's aggravating. I mean, it's not only at the doctor's office, it's a lot of places when they call. I just went recently to buy a truck, and I didn't know when I left that because the person that sold me the truck had known me for 15 years, they kept accidentally saying she. So when I left, the person there said they don't know what they need to be. If I had known that, I'd have put the truck back on the lot. I mean, I'm really telling you, I would have put the truck back on the lot. And instead, they sent him home and suspended him for the day for being there for me, saying, no, this person is a good person. And they were trying to stand up for me. And instead, they should have just let me stand up for myself and told me, but they didn't. And that hurt me. And I was messed up for a few days over that, and I was real scared because, you do get paranoid when people realize who you are and that you have transitioned.
I can definitely agree with that. As far as that fear that comes when basically you're outed somewhere. When we're talking about what is it that can happen better at medical facilities, I feel like right now, the way everything's happening in the world with COVID, there seems to be a lot of compassion in the hospitals when we're talking about COVID and people losing family members that they can't come see. And just, I feel like the compassion level is very high right now because of COVID. When in reality, if you're working in a medical facility, this level of compassion that we're seeing for COVID should be across the board all the time anyway. Everywhere, but specifically when we're talking medically, that compassion should always be there. There should never be that doubt of, well, I'm not sure who you are. I'm not sure what you are. Like when someone comes to you and said, this is who I am, or when you've seen, the changes that they've made, that compassion should already be there. And I think that that's one of the things that medically speaking, when you're talking about bullying and violence, and even in law enforcement, when you're talking about bullying and violence, there's a certain compassion that should come with having certain jobs. And to me, it should just be a reevaluation of self when you can't seem to have that compassion for any specific group of people.
Ames, you know, I've taken on this journey for a number of years, and I've been more proactive to the question in my own personal journey and travels. And even as recent as a couple of weeks ago, when I was doing a panel discussion with several doctors here in Charlotte through Avant, this similar question was asked of me. And when I speak of being proactive, I love to go into whether it's my long-term primary care physicians or someone new, assuming that they are not mind readers or they have a lack of empathy towards our community in particular, and I speak of the LGBTQIA community in particular, when we ever go to see a physician or something of that nature. And I love to have that opening conversation with them and revealing to them that I am a trans woman. I transitioned back in so-and-so. I've had these surgeries. Again, these are all to help the physician and nurses who are caring for me to render not only the proper care, but to establish that platform of respect and dignity that I'm so demanding upon those who I come encounter with. I want the doctors to know that, listen, if you want me to treat you with respect, I'm going to ask you to do the same. So here it is. My pronouns are, or my preferred pronouns are, she and her. I would like for you and your staff to use those. My name is Deborah. I'm not a he, I'm a she. And we have these conversations, and I continue to have these conversations because, again, the assumption can be out of their fear, discrimination, or what have you. But I just believe in being proactive in the process to help educate them, to help bring them forward into a 21st century kind of behavior of respect and empathy.
Reverend Deborah, how has that gone for you? Like, have you universally, like when you have that talk with your healthcare providers, do they grant you that respect? Do they use the right name and pronouns?
I have yet to have any nurse or doctor use the wrong pronouns or call me by anything but. And it's a wonderful conversation, and partly because I remember having this conversation about 6 weeks ago with my endocrinologist. And he reminded me, he says, every time you come in here, you have a smile on your face, you come with this upbeat attitude, even when you're not feeling well. And I said, that's part of this process, is how one presents themselves and conduct themselves in this situation. So it's really gone very well for me. But I've heard so many negative stories, like I'm hearing from Naji and several other people who are actually still dealing with this form of discrimination and lack of respect, which really infuriates me to really continue to lend voice to those who are not on that same platform that I'm on, to speak to these providers in a way that make them look at whether it's the application that we have to fill out with the proper use of name and pronouns. All of these things are important when going in there. And so it's really worked out really well for me.
Tonya, I know you do some direct patient care. How are these things hitting you as a provider, or what have you found to be helpful in preventing violence and in making a good patient experience?
Yeah, I want to say everything that people have said already makes a lot of sense and is consistent with what I hear from people that I provide care for. So I think there's many things that we can do both in the clinical setting and outside. I think as human beings, before we even get into the setting where we're in a patient-provider interaction, it's our responsibility to understand our communities that we're providing care for know who they are, know what the issues are, and where we can be engaged to be engaged in improving the health of all of our communities. And I think that's a human responsibility, and especially as someone who has taken an oath to improve the health of your community. And I think in the clinical setting, I really appreciate the recommendations around names and pronouns. And I think in addition to changing the forms, the onus shouldn't be on the patient to have to do that. I have mad respect for people who do that and can walk in and speak their truth and demand that respect. And it shouldn't be necessary. There should be a standard way in which healthcare providers are trained and then train their staff to treat every person who comes in with respect and dignity, ask everyone for their pronouns, ask everyone what name they want to be called, document that so it's consistently used, and make sure that the entire staff does that.
I suggested to the Novant doctors here that perhaps when they hold one of their yearly symposiums where all the doctors from all over the world come to talk shop, to invite a trans person to one of the symposium and put them into the schedule format, because I agree with you in terms of trying to get them to be more proactive. The medical industry is one of the industries, in my opinion, that are still a decade behind and is playing catch up. And because of people like myself who are more proactive, there are so many more, unlike me, who are very hesitant or very fearful, and for various reasons, and their reasons are justified. And so I think that if we are given the opportunity to be in the mainstream of this conversation, where we're in a group, where we're the minority in this group setting, and the spotlight is on us, where we can actually have this kind of conversation, a presentation and then conversation, I think that we can begin to see some dramatic changes in the medical industry, the way the doctors treat patient-doctor care, as well as the entire staff, from the documents that we have to fill out, all the way to the care and the way we interact with each other.
I just want to add to that. I totally agree. And the way, Deborah, the way you said that, make sure we have the opportunity to be in the right places in the forefront, because I'm like you. I'll go in and I'll say what I need to say so that we don't have any confusion. But there's so many in the community who don't have that within them to do it. And the reality is, just like you just stated, Tanya, it should not be up to the patient. Every patient should not come in and have to explain who they are. I feel like as many times as I've had to do that, I should have received a copay rather than pay a copay when I'm educating those that are in the office with me. I mean, it's just, that's really what it boils down to. And I think that it's important for people to understand not all trans people are advocates. Not all trans people want to do just the simple things that we're doing here and having this conversation live. Everyone's not going to want to do that. So to come across someone that is trans and then say, oh, well, can you tell me, that may not be their thing. And it's rude and very disrespectful, especially when you have so many organizations now, you have so many out and vocal trans folks now who will speak up, who will, put in and do the work, that to just ask any random trans individual, it's just rude and disrespectful. So we shouldn't have to do that. We shouldn't have to teach and educate our doctors because they don't want to do it on their own.
Yeah, if you need to bring in some trans people and pay them. Make sure that you pay us, for the expertise that we're passing on, for you to have a better practice. Easily the number one thing that I hear and that I encounter myself in accessing healthcare is that providers, whether it is intentional or not, sometimes it is not intentional, but for whatever reason, they use the wrong name and the wrong pronouns. And something that seems as small as that can create a huge barrier for trans people accessing care, even if you, as a PA or a licensed practical nurse or a physician, know that you are addressing people appropriately. Make sure that your front office staff are doing that, because it's not always the case, I can say. And a lot of what we've been talking about has been in the vein of what is necessary to establish a good patient healthcare provider relationship, and that the basis of that needs to be things like respect and compassion and trust. And I wonder if the panelists have thoughts about how healthcare providers, like why there are barriers of trust in the trans community, and what they can, potentially try to do to increase trust. It's especially important right now in a pandemic.
The first thing that comes to my mind when you talk about trust was actually on one of the slides that was shown earlier, about how when it comes to the Black community, there's not a lot of trust in the medical field. And when you talk about Black women, there's not a lot of trust in the medical field. It's historical and it's fact. And so I think understanding that is fact, the fear and the distrust stems from, so many things that happened in the past medically without the knowledge of the patient. The Tuskegee Airmen, for example, where medical persons were running tests using Black men. And that's a hard thing to get over. And with that comes, sure, maybe my generation didn't know about that, but my grandmother does not trust doctors, period. When I told her about my transition, and the first thing she said was, "You going to a doctor to do what? Where's this doctor?" Like, I had to pull up the internet for her and show her. I was like, here is the work. This is the research I've done. And she's like, "Well, you've looked into it. I don't trust it." She said, "The minute you wake up, I don't care if you can't say 2 words, you call me." Because she, other than her generation and the distrust anyway, she also has a funeral home that she runs. And she has said to me, so many people have gone to the doctor and ended up to come see me. And so, but the experience, the facts, the historical facts, on top of her personal experiences, it just builds that distrust, and then it passes down. So you have someone who's at this point, I think, if she's not 90, she will be tomorrow. She still smokes her cigarettes. She still runs her business, and she still barely goes to the doctor. Do I think that's a good thing? Of course not. Because I'm like, oh my gosh, you need to go. But at the same time, she's almost 90. So when you have that distrust, and then you see, well, I can see this person is still doing well. I see this person doing well. It's different for everyone, but that distrust is so hard to gain. And who knows where you started? I mean, even now we're talking about COVID vaccines, and folks are like, I'm not doing that. We see the facts. We see the people that are being sick from COVID. We see the people that are dying from COVID. But we've also seen the years and the years and the years of using people as lab rats. And it's different when you tell someone, hey, this is a trial. We don't know what could happen. You sign this, you have the option of belonging to this trial and seeing what happens. Versus, oh, no, that's fine. We do this for everybody, no problem. So that trust, I don't know where to begin for it to be regained or gained. It's just going to have to be an individual decision of pros and cons, is what it boils down to.
Greg,
It's sad that we are in this political climate and nation that we don't have to go many years. We just look at the recent events that creates that fear and animosity towards one another. And so when it comes to whether it's looking for a job or housing, or whether we need to focus on our health, people of color in particular are generally on their deathbed, so to speak, before they really are convinced that they need to see a doctor, because that trust is missing. And it's continuing to be proven that we can't trust many simply because of the way we're treated from day to day. If we're just walking down the street, we read in the newspaper, or we see on the, well, newspapers are pretty much fading now. We see on the social media pages, we see on television, a Black life was taken walking down the street, or yanked out of the car, or because they were reaching for something. You can't build trust. How do you gain that trust? And so if you're asking us to go into the doctor's office to see about something, and the first, we're already dealing with a lot of complexes, issues that really keep us on pins and needles in the first place. You know, if we have a heavy voice like I do, yes, sir. What part of me looks like a sir? You know, especially when I say, hi, my name is Deborah. You know, all of these things are what keeps us from trusting people. And so we're still forced to try to find ways to help bridge that gap. And this is why I am somewhat proactive in going in and having this, you know, having this initial conversation. Hi, it's a pleasure meeting you. I'm Reverend Deborah Hopkins, or I'm Deborah, and I'm trans. My pronouns are. You know, because I'm trying to build, I'm trying to build the level of trust. I still think this nation is still a long ways from trusting government, the things that are important to us as a people. And I'm praying that this new administration is going to come in and will be able to do some things to help bridge this long awaited gap that has been missing, in my opinion, since the founding of the Declaration of Independence.
Well, my issue with the trust is that when I first went to the doctor to find out I had heart trouble, the first thing the doctor told my mother was, no, I just think she's pregnant at 12 years old. Never had sex. The next time I was distrusted with a doctor was at Duke University, doing experimental catheterization for the first time they were doing it on me, a man from Texas and somewhere else. They punctured my heart. So, and then the last time I was really about fed up is when I really started in my transition is going to a doctor's office where somebody I knew, family, and they wouldn't change my paperwork for my name. So my insurance wouldn't pay for it because they were putting it in my own name. So there's a lot of distrust. And, you know, I was like Greg was like saying, some of us don't like to speak out. Well, if it wasn't for Greg, I probably wouldn't be speaking out, you know, some of the stuff that he went through. And then I went through it. And then when I went through it, I was like, wait a minute. I explained it to my mother. She was like, I can call you by, I said, no, not my dead name, you can't. You don't know that you put a tag on me. I happen to walk in the bathroom or somewhere else and I get killed. And then you going, oh, why somebody killed my child, I need to get compensation. No, you don't, because I told you the same thing that they did and you caused me to get killed. You know, using our dead names and we don't look like our dead names can get us killed. That's a lot of distrust, but there are doctors' offices who are willing to make the sacrifice to teach their employees, but the application starts first too. The insurance companies, all that. All of it needs to come together. And like you said, we need to get paid to go and speak and talk about, you know, what they're doing to us, because it does hurt us when we go and we get inside. I just had throat surgery, and the lady saw on my paper, it said female, which I hate that. Because of the insurance, I have to keep that because I haven't had Bob. I go in, the lady runs behind me. Oh, I got the wrong gender on the paperwork. I said, I go by the pronouns, he and him. And they were like, well, what did we put? I said, well, to get my insurance paid, you're going to need to put this and you got to say that. And they were baffled. It just took forever at the desk. So I don't know how to change it. I will speak about what's going on with me with the doctors. And sometimes some doctors are very short with you because they don't want to talk. You know, some of them don't want to change with the times. We need more trust. I mean, especially like Greg say, being Black and That's more terrifying than anything. You can get pulled by the police and you tell them, don't search me. They said, no, you're a male, you got to get searched. And you go, no, 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 you can't touch me. You know, by law, if you still have the female parts, a female has the search and seizure here in South Carolina. And if I go into prison, if I don't tell them that I have the female parts, that's another charge. So you just don't know where the line is right now.
Yeah. You know, Ames, we live in the state of North Carolina, and you know this all too well. For the last 4 years, trans people in particular have been stripped of legal protection because of the rescinding of House Bill. You know what I'm referring to. And we just saw an election of 71 million registered voters who had voted for the outgoing administration, who really resonates hate, discrimination, and evil in a way that none of us can put a face on. So where do we begin to gain that trust? Because one of those 70 million could be that doctor that we're going in to see who has a discriminative of attitude towards me, has the, as the old song says, by they smile in your face, the backstabbers, they're smiling. Yes, oh, we're here to take care of you. I've got one in here. Now I can eliminate one more from population. Listen, where did the trust come? This is the very thing that we walk on pins and needles on, because we already know we're in a state that does not have any protective laws for me. If I walk out this door right now, anyone can beat the living hell out of me and not be prosecuted. We have a president right now that continues to say that if he walked down New York City and took a gun out and took someone's life, no one, he's absolutely right. So where do we build this trust? Where do we find this trust? When we see it on the news, lives are being taken. When we go into the doctor's offices and we're continuing to see our dignity and respect stripped from us because they carelessly are not showing the proper empathy and respect that is required of all patients under their hypocritical oath that they take. So where do we gain this trust?
And for sure, the president's, Department of Health and Human Services has also been espousing that same kind of, hatred and disavowing the humanity of trans people with this rule that was put out during Pride Month. I'm so grateful to y'all for your candor with these answers, and I dearly hope that the healthcare providers that are listening will engage in some reflection. I wonder, have there been any questions from the audience, Tonya or Nastasia?
We haven't had any, but if you do have questions, please feel free to put them in the Q&A tab and we can answer them.
I just want to comment on what people have been saying, that I sit here thinking about how often I hear colleagues in the healthcare profession say, how can we get people to trust us? And I feel like my answer is always the same: be trustworthy.
Yeah, yeah.
That's really all you can do.
Yeah.
Because people's distrust comes from real experience.
Yeah.
Absolutely. When I think about the conversation merging a little bit of Fred, you talking about insurance, Deborah, you talking about politics. The interesting thing is how thick that connection actually is. And it's disgusting. When so many of the procedures that insurances like to kick back or say, oh, your gender must be this or that, it makes no sense, because that, you said, Fred, you mentioned having something to do with your throat. Every person has a throat. Why is what relevance is the gender identity for someone needing care for it. You know, it makes no sense. It makes absolutely no sense. I know there are, you know, yearly routines that each person has to get done. And insurance says, oh, we're not covering that. The routine you had doesn't match your gender. But as an insurance company, you cover this anyway. The reason it's coded that way is so that my doctor's office can get their little piece of the pie to rebuy those supplies. You cover it anyway. What relevance is the gender? The doctor knows what procedure they're doing. The doctor knows, hey, this is a yearly, whatever, I need these items. So if that's what's foul, those are the items the doctors need replaced. What difference does it matter? You know, when it comes to the basic yearly self-care, self-routines that have to be done, that's what makes me so angry about the insurance. But it goes back to the fact that politicians have their hands, their pockets, their wallets so deep into the hands and pockets and wallets of big pharma that on the bottom of the totem pole, here we are trying to go get a yearly physical. You know, that really makes me mad.
I remember hearing, was it a year or two ago that there was a shortage of estrogen? Yeah, Tonia's nodding. And I remember just being really fearful with the federal government, like, oh, is it gonna be harder to get testosterone? Until I realized, like, you know, white men need testosterone as they get older. So it is not likely that it's ever, you know, going to disappear off the scene. They'll find a way to get it when they tend to come out of the woodwork as they turn 50, like I just turned. We're almost at the end of the hour. Just want to check back and see if there were any questions that we should answer. Oh, I see a Q&A. Okay, so Kate asks, thanks so much for your discussion and honest sharing about your experiences and what needs to change. I'm very excited to hear about the new community health worker project you're implementing. Can you say more about what you'll be doing on the project?
I can speak to that. So the project will, it's underway. We're getting started on it. But with the training, we will be training 10 people as community health workers. They will go through an online training, mostly online training, probably all online training with our partners in Columbia, South Carolina at the Center for Community Health Alignment. In addition to being trained with the core foundational aspects of being a community health worker, they will also receive training in HIV 101 and gender affirming care. And then at the end of the project, we will look to pair them up with organizations that hire community health workers. And during that training, they'll also have the opportunity to have some practice in what it would actually look like to be a community health worker. We are so South Carolina does have credentials, requirements, what you need to be a community health worker. And so at the end of the training, they will have all of the required credentials to be a community health worker in South Carolina. And North Carolina is in the process of creating these standards. And so we're hoping that folks from South Carolina will also be able to work in North Carolina with that training as well.
Thank you, Nastasia. Oh, go ahead, Tonya.
I just wanted to add, speaking to what everybody said about the importance of paying people, we understand that this is a research study, and we also understand that we're paying for the training, but because it's a research study to see if this works, if this addresses some of the issues, people who are community health workers and are hired by us will be paid for their community health worker time as well as the training. So I just wanted to make that clear, that we're not asking people to volunteer to be trained, that we understand that this takes time and effort and money. And so, you know, we want to make sure that we pay people for taking part in the training as well. And that we're prioritizing, I think we can say this, we're prioritizing trans people of color. Ideally, we would like for trans people of color to be the ones who are trained to provide services for trans people of color.
I put my contact information in the chat. I'm not sure if everyone was able to see it, but I will be sending out a follow-up email after the webinar as well. And so everyone who's attended will also have my contact information that way.
Any parting words, Tonya, as the head of this study and the person who's kept it going for the last year?
Well, I'll say it was Nastasia and I, it takes a village. And actually many of the people who are here, including you, Ames, and I know several of the participants are part of our sort of community board. So there's a group of people from North Carolina and South Carolina that meet at least monthly to talk about the progress. And I'm really excited because I love that we were able to find out what the community's priorities were and that we were able to parlay that into hopefully something that will address some of the community priorities. And we will continue to search for funding to try to do those things. If you haven't taken the survey, we're leaving it open for a while, so you can, if you want to adjust the priorities, you can add your thoughts about those priorities. And I also just want to say I'm really grateful for all of you on the panel and the people who showed up on a Sunday night to do this, to share your experience, for us to learn from. It's been fantastic. And I'm going to shut up now. All right.
I will add, Ames, that I just added the link to the survey in the chat. It is still open. We are at 94 participants and we would like to get to 100 if possible. The only criteria is that you are a trans person living in North Carolina or South Carolina.
Ames, if you will, for me, there is a couple of years ago, I believe it was Equality out of Asheville that produced a pamphlet for the health community for those to follow, to find different providers and things of this nature, health providers, counselors, and things like that. I know I have it in my links someplace. I just can't find it right now, but I know that you probably have a copy. I think that all of the viewers need to have a copy of that, or at least the link to it, so that they can, for the future going into 2021, know some names, contact number, or location for healthcare to address their healthcare needs, whether it be with combating AIDS, mental health, or just their primary care physician. There are quite a few names on there, and it covers the United States as a whole. Not all of them, it's just a few names from each state in the various areas that I think that our listeners can benefit from.
I will say this, we only have, in Columbia, South Carolina, only one doctor office who does female to male, and that's Dr. Ada Stewart here at the, some of them call it the Waverly Clinic or Eau Claire, but they do male to, but she's the only one here in Columbia. Now they have doctors in Charlotte, North Carolina, and all that, but she is the only one here. And the one thing about her, if you are ready to go through your transition, she will move your name to the top of her doctor's list so she can see you. And not only that, she gives you her cell number so that if she's not available in the office, you can call her. That is, and she's also a family doctor. So you kill two birds with one stone. You got your family doctor and your doctor for you transitioning.
It's awesome.
It's a few more. There are definitely a few spots that are, realizing that this is a need. So there are definitely some other places that are starting to, open up and be, very specific and intentional about being inclusive. So I know that there are several. We got links popping up. We got several different, links and organization and resources. I think the key is, one, folks knowing the resources that are there, and two, the consolidation of resources in some capacity to kind of help make some choices and decisions easier. And I feel like from what I've gathered from being on this panel and the work we've been doing prior to tonight, I feel like that's, the direction we're headed, is just making sure, because no one wants to have to all go to specifically the same person, because what has happened, in my opinion, is sometimes those folks can get burned out because now it's like this influx. And so having, you know, that the resources to know, hey, you can go here or you can go over here. Like there's just, you know, different spots. So you can choose, you have the option of being able to choose the doctors and the folks that you want to, you know, deal with as far as your health concerns.
And also more trans people become healthcare providers. Yes. We make it so that, you know, we can see ourselves in you. I reckon we are about out of time. Am I right, Nastasia? Okay.
Yes, we
I will
are.
let you close it.
Thank you so much for the lively discussion and for your honesty and attention. I really appreciate it, especially since it's so late on a Sunday evening. We have a lot of links that were generated in the chat, and I will send those out as well at the in the email following this. Like I mentioned, I'll also be sending out the slides that I presented, as well as the flyer for the community health worker research study. The one thing I did not mention is that we took all of the resources that participants curated in the community asset mapping exercise, and we put them into a single Google Doc that I will also share around. And I've also put a form in that Google Doc so that if there's any resources that adhere to any of those barriers, that people can add them for us, and I'll periodically update it. So thank you so much. That brings us to the end of our webinar.
Thank you.
Everybody have a safe and happy holiday season.
Thank
God
you.
bless you all.
You too.
See you on the 9th, Ames.
Good night, everyone.
Good night.